Hey, it's midterm one again, and this video that we're going to go today is basically just a follow-up from the video that we had in regards to word roots and suffixes, giving you just a little bit more vocabulary terms. So a lot of this is going to be a repeat. There'll be a few new words we're going to add here, but basically that's what we're going to talk about. We're going to just give you another longer list of vocabulary terms to think about. Okay, so let's go ahead and get started with that and get show on the road. Adenoids. Now we talked about adenoids the other day. Okay, and adenoids we know are basically just a third set of tonsils. We mentioned in our previous video that we have three sets of tonsils. One that are actually in the back of the throat, okay, back in this area right here, and those are called the palatine tonsils. This area right here is called the palate, and they're right there at the end of the palate. They're called palatine tonsils. We have another set of tonsils that are actually right back here, which are in the back of the tongue, which are called lingual tonsils. And the third set of tonsils that we have are right back here in the back of the nose, and those are called the adenoids. Okay, and the adenoids, they're the same type of tissue that we have in the regular tonsils and in the lingual tonsils. And again, they're to trap things like bacteria and viruses, so they can be transported to lymph nodes to be destroyed. Okay, again, a lot of times what happens is we have these people with allergies, and sometimes these adenoids, instead of being small, get much larger. And what they do is they get very large, they get hypertrophic, everybody should know what that word is, and sometimes when they get so big, they actually block that nasal passage, which results in difficulty breathing through the nose. These people tend to be more mouth breathers, which results in more pharyngeal or throat infections, upper respiratory infections, and things like that. So anyway, that's the adenoids, and the adenoids are this third set of tonsils at the back of the nose right here, okay? Usually, like I mentioned, I think in the other video, that when they take out the tonsils, they usually also take out the adenoids too. Okay, so those are the adenoids. Okay. Next vocabulary term we have here is the alveolus. Now we talked about the alveolus or alveoli, okay, from before in our last video quite prominently. And these are exceptionally critical because what happens, these are all these little air sacs, these little air bubbles that are basically at the end of the bronchioles. The bronchioles are the smaller airways. Okay, we'll talk about those again in a second. But finally, when we get down from the trachea to the bronchi, to the secondary bronchi, to the tertiary bronchi, and get smaller and smaller, and finally we get to the bronchioles. At the end of the bronchioles are these little air sacs, and the air sacs are the areas where we have the gas exchanges. The carbon dioxide going from the blood, into the air sac so we can exhale it, and the oxygen from the air sacs from inhaled air into the blood so we can transport it around the body to be able to use to help to burn nutrients, which are fuels for the production of energy. Okay, these alveoli are exceptionally critical. What we find is in certain diseases, and we'll talk about this when we have another video in regards to pulmonary conditions, things like emphysema, the structure of these alveoli become destroyed, and we have larger air bubbles in the lung, which are sometimes called blebs, which basically have no function in gas exchange. And these blebs get larger because the alveoli become destroyed, and things such as emphysema, what happens is there's a larger area in the lungs that really has no is not involved in the process of exchanging gases, which is a problem. Okay, so these alveoli are really important. I think I mentioned also that what happens, these alveoli become a problem in premature babies. If a premature baby is exceptionally premature, what happens is some cells that are inside the walls of these alveoli, which normally make something called surfactant, which keeps these little bubbles, these air bubbles, these alveoli open. What happens if these, in a premature baby, these pneumocytes type 2 or type 2 pneumocytes, they don't work. They don't make the surfactant yet, and they can't keep these little alveoli open. And as a result, the alveoli collapse. That's why an exceptionally premature baby is going to go on a ventilator, be able to open up these little air bubbles and keep them open. Okay. So anyway, those alveoli are these little air sacs in the lung. Again, there's millions and millions and millions of those. The next word we have here is apex of the lung. Apex of the lung. And when we look at this diagram right here, this makes a lot of sense, okay? What happens is, let me get rid of my picture down here so I'll get that mug out of the way. If we look at the top of the lung in this area, which comes to a point, that area up there is called the apex. So the apex of the lung is the top area of the lung where it comes to a point. The base of the lung, okay, the base of the lung is just the opposite. The base is the flatter area at the bottom. When we look at a heart looks like this, comes down to a point comes like this. This point area right here of the heart is called the apex of the heart, and the flatter area up in here is called the base. But in the lungs, again, that the top portion, which is just underneath the clavicles, clavicle is going to be here, clavicle is going to be here, okay, and that area just behind the clavicle is called the apex of the lung. Just you don't have to remember this, but I think it's sort of interesting. For some reason, the upper areas of the lungs actually aerate much better than the lower regions of the lung. The lower regions of the lung tend to not fill nearly as fully as the upper regions of the lung. Okay, things like tuberculosis, which we'll talk a little bit more about in conditions, when they usually find lesions, or when they usually find these, they're called granulomas. The tuberculin mycobacterium forms a little granular material around, like scar tissue around it. And they're usually up in the upper lobes, because these areas in the apex of the lung have a tendency to aerate a lot more than the lower portions of the lungs. But that's just beside the point. Just something, just for your own information or excitement, or probably not excited, but for your own information. Bronchioles. Okay. Now again, once the trachea branches off, okay, we end up in the bronchi, okay, which is going to be the word that's going to come up next. But what happens is when I get down the bronchi, here's the trachea right here, we're going to go down to primary bronchus, secondary bronchus, tertiary bronchus. Eventually what's going to happen, I'm going to get down these very small airways, and these little small airways are called bronchioles. Now the thing that makes a bronchiole different from the bronchi is the wall. When we look at most of the bronchi, embedded within the wall of the bronchi is a cartilage ring that holds the larger airways, the bronchi, open. On the other hand, when I get down to the bronchioles, we lose most of this cartilage, which is then replaced by muscle. And I think I mentioned this a little bit in our previous video. These muscles, if they contract, they make the opening of the bronchiole smaller. Okay, so if they contract, the muscle squeezes down on the bronchioles, and they become, and the airway becomes smaller, and it sends less air to that part of the lung. If those bronchioles relax, what happens is that the bronchioles will dilate and get much larger if the muscles will relax. People with asthma, again, sometimes what happens because of allergy or cold or exercise or something causes the muscles and the walls of the bronchioles to go into spasm. They narrow down, and there's a lot of fluid and inflammation inside the alveoli, which further block the bronchioles. That's why they have trouble. They get air in, but they have a difficult time getting air out. That's where you get the wheezes, trying to force the air out. And so what they do is they give a bronchodilator, which basically relaxes the muscles in the bronchioles. And when it relaxes the muscles in the bronchioles, it dilates and gets more air in. Okay, bronchodilators, or another thing called epinephrine, which will do the same thing. Okay, so those are the bronchioles. If I talk about bronchi or bronchus, okay, these are the larger airways. Okay, if I look at this diagram right here, okay, obviously this larger area up in here is the trachea. The trachea right here divides, and again we talked about that last time, that little V, that upside down V word divides. That's called the carina, C-A-R-I-N-A. It's called the carina, which means keel. But what happens is that after the carina, I have my primary bronchus, which comes down this way, okay, which are very large. They enter the lungs right about here, enter the lungs right about here. Those primary bronchus then divide into secondary bronchi. Okay, they divide into secondary bronchi, and those secondary bronchi then divide into what are called tertiary or third degree bronchus, which gets smaller and smaller and smaller. So you have one, and then that one divides into two, and those that get smaller and smaller, and we continue to get much smaller until we finally end up getting down to the bronchioles. Okay, so those are the bronchi or the bronchus. Again, they're usually surrounded by cartilage around them to keep them open. Okay, carbon dioxide. Carbon dioxide, we know, is a respiratory waste gas. When tissues undergo metabolism, when they're making fuels, when they're making energy from fuels, when they're burning fuels to make energy, what happens is one of the byproducts that's frequently there is carbon dioxide. And so we have to get rid of this carbon dioxide, because as the carbon dioxide builds up, it decreases my respiratory drive. You don't want to breathe nearly as much, okay? So as a result, we have to get rid of this. So the carbon dioxide is picked up at the tissues, put in the capillaries, and taken back to the lungs. When it finally gets back to the lungs, the little capillaries that are around the alveoli allow the carbon dioxide to go from the capillaries into the alveoli, and then we can exhale them from that, because once the alveoli, they come up through the bronchi and out, eventually out the trachea. Okay, so that's what carbon dioxide is. We all know that's a waste respiratory gas. Cilia. Okay, now this right here is not like a, like an abstract picture or anything like that, but these are called cilia, okay? And these cilia are actually pretty important, okay? The area of the trachea, the bronchi and stuff like that, along the wall, you can't see, these are microscopic. It looks like these little hairs, okay? And these little hairs beat. They have sort of like a beating motion. They sort of beat in one direction, okay? And what they do is when we breathe in, we're breathing in all kinds of little particles. Now, some of those particles are trapped in the nose and the mucus and the hair in your nose and things like that. Some of those particles get trapped on the tonsils, the adenoids, the palatine tonsils, the lingual tonsils. But along the airway, we have these small little things, look like a shag carpet. What happens, that particle gets trapped right here, somewhere along that, okay? As it's coming down the airway, and boop, it just gets trapped right there. Then what happens is these cilia, since they beat, they have a beating motion. It's like seaweed. You watch in the ocean, sort of beat. What will happen is the cilia here transport that particle to here, which then transports that particle to here, which then transports that particle to here, which then transports the particle here. Eventually, they go all the way up to that area of the carina, okay, which is right in here, and in the area of carina, there are specialized cells there that actually produce what's called a cough reflex. So when I get all the garbage that's deep in the lungs, it's transported like body surfing this stuff all the way up until it gets to the carina. When it gets to the carina, it causes an irritation, which then allows us to expectorate or to be able to spit that stuff out, okay? And that's what these cilia are. The cilia are these small little hairs that line. We'll see cilia in other places in the body besides the airways. But the cilia are there to trap things. Now, one of the things that's important about the cilia that I should probably mention here is the fact that smoking, the gases, which are noxious gases in tobacco smoke, have a tendency to paralyze the cilia. The cilia don't work. As a result, that garbage gets down in the lungs, down in here, and guess what happens? Nothing. It doesn't go anywhere. Simply because those cilia can't beat and transport that garbage up the way, up the area to the carina to be coughed out. As a result, what happens is that all the bacteria and garbage and debris sit down there, cause a chronic irritation. And that's what we see with chronic bronchitis. Well, people who are long-term smokers, they have repeated lung infections because what happens is they trap all the garbage, all the gunk, all the mucus, all the bacteria, all the debris in there, and they don't get rid of it. They can't cough it out because they can't move it up the airway to the area of the carina to be able to cough it out. Okay, so as a result, that's one of the good reasons why people shouldn't smoke. Smoking paralyzes the cilia, therefore that helps in that process of destruction of the lungs when the lungs no longer work because they can't get rid of all this debris and garbage that gets down deep inside the lungs that we breathe in. Okay, so that's a little about the cilia. Diaphragm. Now we've talked about the diaphragm before, okay? And the diaphragm is more than just that division area between the thoracic cavity and the abdominal pelvic cavity. And I mentioned this in our last video, okay? So my diaphragm is sitting right down in here like this, and here's the abdominal pelvic cavity down here, and this would be the thoracic cavity up in here. The thing that's important about the diaphragm is a muscle. Got to remember that it's a muscle. And that nerve that we talked about phreno. Phreno means diaphragm. It's a word root that means diaphragm. That phrenic nerve comes down the surface of the heart and attaches the diaphragm here and attaches the diaphragm there. And what happens is when the phrenic nerve is stimulated, it causes the diaphragm, this is called the dome of the diaphragm, it causes it to flatten out. By causing it to flatten out, it increases the vertical diameter of the chest cavity, and then the ribs go up and out with these external intercostal muscles, the muscles between the ribs, so that it decreases or increases the transverse diameter. And what that does is it increases the entire volume inside the thoracic cavity. And I mentioned in our previous video, there's something called Boyle's Law. Boyle's Law says increase in volume results in a decrease in pressure. What that does, it creates almost like, I can't say a vacuum, but sort of like that. The pressure inside the thoracic cavity now is less than the outside. So if we have the head up in here, and now that because the pressure outside in the atmospheric air is greater than the pressure inside the lungs, if we open our mouth, breathe in, now air just goes and it gets down through the trachea, goes down into the lungs and fills the lungs. Okay, so that diaphragm is exceptionally important when it comes down to breathing. There are certain situations where people get diaphragmatic paralysis, like sometimes after thoracic surgery, if they damage that phrenic nerve. I remember when I was a kid, nowadays with polio. Polio, they go and they put a couple drops of something on your tongue and hey, you're good to go. You know, when I was a kid, it was when the polio vaccine was first coming out, okay, and they had to give it by injection. And I remember standing in a big long line. They used to stand outside the schools to make everybody get injections or immunizations for polio because polio was getting big at that time. And I remember my mom and dad saying, hey, listen, you know, if you don't get this polio shot, that what's going to happen is you might end up in an iron lung. What happens to some of these people with polio affected the spinal cord, and the result of polio depended upon where along the spinal cord it caused a problem. If it caused a problem in the spinal cord up by that C3, C4, C5, where that phrenic nerve, like we talked about the last time in the last video, originates from, it actually causes a paralysis of the diaphragm. The diaphragm can't move, therefore they have difficulty breathing. So they used to stick them in a chamber that would actually help them to breathe. Okay, their head would be outside the chamber, but the rest of their body was in this tube. Okay, a closed tube that actually changed in pressure to be able to allow them to breathe better. Okay, so anyway, that's the diaphragm. The diaphragm is really important because of that. Okay. Epiglottis. Now we talked about the epiglottis last time, and that epiglottis we know is that little flap of tissue that sits right here at the back of the tongue. Right here at the back of the tongue. And when we eat, that epiglottis comes down and closes this area, because this area where the vocal cord is, the vocal cord area right here and right here, that's called the glottis. Epi upon the glottis. Glottis upon the area of the vocal cords. And if I'm actually going to look at that, we showed this picture before, okay, and this is one we had in our last video, but it's worth looking at again. And what happens is what we're seeing here is the vocal cords. That's a vocal cord, that's a vocal cord there, that's vocal cords are closed, okay. There's a membrane right here that the trachea would be sitting right underneath there, just like that, okay. Because you see, when the vocal cords are open, this area right in here is inside the trachea, okay? And there's a little piece of cartilage right here with muscles that attach to the end of the vocal cords that either open the vocal cords or close the vocal cords, okay? But this area right here in the front is that epiglottis. So the epiglottis is going to sit right here. So what happens is when we eat, that epiglottis is going to flap over the top of the vocal cords. So therefore the food is going to go down behind, and down behind is what? The esophagus is going to be sitting behind. Esophagus is going to be sitting behind the trachea right there. Okay, so that's the epiglottis, and that gives us into a good segue into the glottis. Okay, and the glottis is the area of the vocal cords. Okay, which we saw in their last little diagram. Expiration. These are a couple simple words here. Expiration is just simply the word that means to breathe out. Okay, so with expiration it's breathing out. Inspiration means breathing in. Breathing out, expiration, breathing in, inspiration. The hilum of the lung. Now, the outside of the lung is sort of like held against this part right here where it looks like concave inside. That's the part that's against the diaphragm. That's that base. This we know is the apex up at the top. And the vast majority of the lung is held either against the wall of the chest, the diaphragm, or there's actually, remember we talked about the mediastinum? There's a membrane in the middle that divides the mediastinum from the right pleural cavity, right pleural cavity and the left pleural cavity. What happens is I don't have blood vessels or airways or anything coming in through the sides. The only place that anything enters or leaves the lung is a small little area in the middle of the lung, okay? So like if here's a lung here and here's a lung here, there's only one little area here and one little area here where things go in or go out. And that area is called the hilum. You can see right here, this is the hilum. You see blood vessels, they're going in and out, as well as the bronchi, which is going in and out, and causes the air to go both in and out right there. So that's the only area. We're going to see this word hilum again coming up in the kidney, because in the kidney, blood vessels and stuff like that only go into the kidney in one spot, and that area is called the hilum. So the hilum is this little small little area on the inside surface, of the medial surface, that's a better word right here, medial surface of the lungs, where things enter or leave, okay? And that's called the hilum of the lung. The larynx, okay? The larynx we've talked about before, and this is a little bit different image of the larynx from what we saw before, okay? Get rid of these scratches here, get all the stuff out of the way. And the larynx is this part right in here, okay? This area right here, this large area right here, is called the thyroid cartilage. If you feel your neck, you feel that's the Adam's apple in males, okay? Females, they have an Adam's apple, but it's smaller, okay? It's flat. If you look at the males, it comes to a point. In females, it's much flatter, Okay, so you don't really see that, quote, Adam's apple in females, but you do in males. So that's that right there. And what that is, that's a piece of cartilage. It's called the thyroid cartilage. Okay, let me erase that. It's called the thyroid cartilage. And what's behind the thyroid cartilage is the glottis, or the vocal cords. Okay, so the vocal cords will be sitting right back in this area, right down here. Okay, now below that is another membrane right here, which is called the cricoid cartilage. Okay, another cartilage. And there's a membrane which is called the cricothyroid membrane, which is between the thyroid cartilage and the cricoid cartilage. If you feel your neck, okay, you feel that thyroid cartilage. And you keep them come down straight down the middle, and you're going to feel a little gap that goes sideways, right about here. And that's that cricothyroid membrane. And you're going to feel another ring right below that, and that's your cricoid cartilage. Sometimes, because the vocal cords are sitting up in here, in this area right here, if somebody has, like they're choking, and sometimes they can actually put something right through this area right here, because again, it's just a membrane, and you poke through that membrane where you're at, and now you're in the trachea. Okay, so basically that's what that's all about. You know, so this area right here is called the larynx. Okay, and the back of the throat behind that's called the laryngopharynx. And what do we see? Here's a good old friend, the epiglottis, that sits right up in there. One thing I should mention here, and I'll just show you here because it's sort of an interesting bone. Okay, and it's that this bone right here. This bone right here. Actually, it's a backwards shaped U. So this would be anterior, and this would be posterior. And this bone right here is called the hyoid. Okay, and this hyoid bone is interesting because it's probably the only bone that's not really attached to another bone. Okay, it's actually suspended in the neck. Okay, if you feel up above the thyroid cartilage in the neck up in here, you'll feel a little hard area, and that's the hyoid. It sits up in there, and basically there are tendons and muscles that will support it from the top, and tendons and muscles that support it from the bottom. There's a number of muscles that do that, and basically it's the only bone in the body that really doesn't articulate with another bone. Okay, it's sort of an interesting thing about that hyoid. They sometimes call it the hangman's bone because when people are hung, sometimes that hyoid bone will actually fracture. Okay, when they have that noose goes around their neck. So that's the hyoid. But anyway, this area down here is called the larynx. Okay. A lobe, okay? And a lobe is basically, if I take the lungs, okay, and we talked about this a little bit before when we did lobo in the last, as a word root before, we realized that the lung is actually divided into lobes, okay, different lobes. We have when we start to think about this, we have, and this says superior lobe, but they most commonly, they call that the right upper lobe. You'll see RUL. This is the middle lobe, or the right middle lobe, and this is the inferior lobe, or frequently called the right lower lobe. And these are appropriate abbreviations for that: RUL, RML, or RLL. And then on this side over here, I have the left upper lobe and the left lower lobe. There's no middle lobe generally in the left lung. This area right here, where it's cut out, is called the cardiac notch. The cardiac notch. And basically, that's because the heart sits in this area, okay? It sits in there. And this area right here that looks like a little tongue, okay? This little area right here, it's called the lingular process of the upper lobe of the lung. And lingular means tongue, okay? And that's what they call that. Now, what divides the lobe are these fissures. The fissure, we know from talking about the muscle, is actually a crack. It's actually a gap. You can actually take and actually pull it apart a little bit, and it'll separate. That pleura, which covers the surface of the lung, actually goes down inside that fissure, inside all the fissures. So it's lined to the inside of the fissure. And sometimes you're actually able to see the fissure, particularly this one right here. Okay, sometimes you will see that horizontal fissure. See this horizontal fissure because it's horizontal. Sometimes you will see that on a chest X-ray. Okay, and here's another fissure. Here's an oblique fissure. Here's an oblique fissure down here. But they're just the division areas between the upper lobe, middle lobe, lower lobe on the right, and the upper lobe and the lower lobe on the left. Okay, so that's the lobes of the lung. Mediastinum. Now, this is a word that we've had multiple times. I mean, if you can't remember this word, you know, you're a little bit behind the learning curve. And we remember that what happens in the thoracic cavity is divided into multiple cavities. Okay, I have a right pleural cavity. I have a left pleural cavity. Right pleural cavity with the right lung. Left pleural cavity with the left lung. And then everything in the middle is called the mediastinum. So that mediastinum is everything that's in the middle. Okay, and inside that mediastinum, what do I have? You have the heart, you have the aorta, coming up in here. You have the superior vena cava coming up this way, the inferior vena cava down here. You have the trachea. Behind the trachea, you have the esophagus. You have a lot of blood vessels, nerves, and everything else inside that. And then we know that there's a fourth cavity inside, which actually covers most of the heart, which is called the pericardium. Okay, it's the pericardium. So that's a little bit about the mediastinum, a word that we all know from before. So that should be an old friend for you. Nares. Nares is just another word that means nostril. Okay, and what happens are actually two nares that we have, you know, in the nose. Okay, this is the external nares right here, and when you stick your finger in your nose, you're sticking in your external nares. Okay, and that's the entry into the nose anteriorly. Here would be the tip of the nose right here. The bridge of the nose would be up in here. Okay, so this area right here is called the external nares. And that what happens is the area back in here. Again, what's back here? There's my adenoid sitting right there. This area back in here is called the internal nares, okay? Sometimes they call it choana as well, choana or nares, okay? And they're just the openings. So you go in through the external nares, and you go out down the nasopharynx through the external or the internal nares or choana. Okay, internal choana. Okay, so basically that's what we have with that. One thing that I think I mentioned before, and you don't really see it here because this is looking at the septum. We talked about the turbinates, which are basically these shelves of tissue that come from the side. But the center of the nose, if you put your finger in one side and you put your finger in the other side, you'll feel there's like a wall. And the word wall, just like we talked about in the heart, is septum. And that would be the nasal septum that divides the right side of the nose from the left side of the nose. Okay. So that's the septum. Couple more words that we need to talk about here. Oxygen. We know oxygen is basically a beneficial gas. Okay, oxygen is essential simply because what happens if I take fuels burn better in the presence of oxygen. When I don't have oxygen, they don't burn nearly as well, and therefore their energy production is significantly less. So we actually make a lot more energy in the presence of oxygen. What happens is, since cells have to constantly work, they constantly need oxygen, which is going to be delivered through the cardiovascular system, but is actually caused by an exchange in the lungs, like we talked about with the respiration. You know, the external respiration, where the oxygen from the air then gets through the capillary or the alveolar walls and gets into the capillaries to be sent around. We can live a little bit without oxygen, but oxygen is really important. Eventually, we're going to run out of energy if we don't have enough oxygen, and the cells will start to die. If cells don't get energy, they can't work. Okay, it's like if you have a car and your car runs out of gas, guess what? You know, you could want to go on all the trips you want, but if you're sitting in the car and you can't run, can't go, guess what? It doesn't work. So that's what oxygen does. Okay, palatine tonsils, and we talked about these before, and these are the palatine tonsils. Okay, so oxygen, palatine tonsils. This little thing right here is called the uvula. Okay, that little thing that hangs down. And if you looked at everybody in your family, you'll probably see that everybody has a little different looking uvula. Some of them are big, some are small. Some people have very minimal uvula. Sometimes the uvula actually has two pieces to it, sticks down, called a bifid uvula and stuff like that. But this area up in here is called the soft palate. And right here, there's a band of tissue that comes this way. You can look inside, and you can see, and yourself look inside them, you know, with a flashlight in front of a mirror. And there's a band of tissue that comes down this way. Okay, and these are called the pillars. This is an anterior pillar. There's one on the back that's back in here behind. You can't really see it. It's called the posterior pillar. What lies between there? The tonsils, and that's that lymphoid tissue, very much like a lymph node. It sits in there. Now this one right here has a little bit of an infection going on. You can see there's a little pus on the tonsil, and so that'd be a tonsillitis in this situation. Okay, this area back here is actually going down, and that'd be behind the tongue going down, and the epiglottis is sitting back here behind the tongue, as well as the lingual tonsils are sitting back there. If I went up this way behind the uvula and behind that soft palate, you'd actually get up to where the adenoids would be. Okay, but you're going down to the esophagus and the trachea if you go down this hole right there. But when we look at this, you know, it's a tonsil there, that's a tonsil there, and again, that's a tonsillitis. You can see a little pus also on this one here. You see this, this is all pus that's on this tonsil on this side right there, so that's a tonsillitis. Okay, so those are the palatine tonsils. Palatine tonsils because they're right from the palate, the soft palate that sits right there. Sinuses. Now we talked about the sinuses before, okay, and these sinuses again are opened areas within the bone, and here's the frontal, we have a couple different sinuses here. This is the frontal sinus right here. This is the ethmoid sinus, the sphenoid sinus. These don't usually cause too much of a problem, the ethmoid and the sphenoid. The maxillary sinus, yes. The frontal sinus, yes. So when people have like a upper respiratory infection or a cold, sometimes they start to get that pain above their eyes or just below their eyes. And that's what happens. The reason why that happens is these sinuses are lined with mucous membrane, like I mentioned in our last video. And mucous membranes do what? They make mucus. Well, if they make mucus, and these are little openings, so the bone comes and divides like this, and that's inside would be the sinus, and that inside that sinus is lined with that mucous membrane inside there. And that mucous membrane makes mucus. That mucus then has to drain out through a little canal. That canal comes down to the nose here, comes down to the nose here, goes up to the nose there, and up to the nose there, okay? And as a result, the mucus, when it builds up, then gets into the nose, and it comes out as nasal drainage, okay? So these are called paranasal sinuses. And when people have a cold, what will happen is that channel, okay, or that opening will swell shut. And as a result, the mucus starts to build up, 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 until it finally fills that whole sinus. And the sinus is lined, again, with mucous membrane, which actually is supplied by a nerve that provides sensation to the face. It's the trigeminal nerve or cranial nerve 5. Okay, provides all the sensation to the face. And as a result, that's why we get this pain. Now we feel this pain because that nerve that's inside that lines the mucous membrane inside the sinus, that trigeminal nerve, cranial nerve 5, becomes irritated. Okay, and basically that's what these sinuses are. Now the maxillary sinus, this purple thing right here, they're not really purple, but they're just here for your own purpose. The problem with it is the tract or the canal. In the frontal sinus, things drain downwards. This one actually drains sideways or upwards a little bit. So they have a little bit more difficult time draining. And that's why sometimes people will have, this maxillary sinus becomes a lot more problem than the frontal. Once they take a decongestant and open up this tract, all the mucus and stuff like that comes out. Also, if you have mucus that develops in there, you got to remember that for the most part, until this closes off, this is open to the outside. The hole that goes inside there is actually inside the middle of the nose. So bacteria can actually get up there. So I've had a lot of mucus in there that bacteria says, hey, let's have a party, and they start to multiply in that mucus. Then you result in a sinusitis, which is basically an infection. Okay. So anyway, that's a little about sinuses. And I think right here, this is going to show you a little that parlor trick like I talked about last time. Okay. If you take, and this is sort of a way to look at what those sinuses actually look like. And what they've done here, okay, is they've actually taken and put a flashlight, okay, like right in here, and you can see a flashlight here, and you'll see this area in the forehead right here glow. And that's because, again, that sinus is usually filled with air, and then therefore the bone is thinner, so you'll actually see a glow. And then this is one where they actually put a pen light here, and when the roof of the mouth will glow if you look inside there. Try it, try it out, see if it works, and it sure would. Make sure you go in a dark room to be able to see it. But you will see the frontal sinus, and you will see that maxillary sinus. Okay, so that's the little thing that you could actually do at parties and stuff like that, and they'll never invite you back. Anyway, the pleura. Now we've talked about the pleura before multiple times. We talked about the pleura when we talked about membranes in body terms. Okay, and we know that we have two pleura. We have a parietal pleura and a visceral pleura. Okay, that parietal pleura is the one, this blue line that we have out here. If I look at this blue line on the outside, that lines the inside of the thoracic cavity, lines the superior surface of the diaphragm, and lines the mediastinum right here. Okay, see that lines the mediastinum right there, right there. The visceral pleura is the green line. Okay, and that's this one in here, and that's the part of the pleura that's on the surface of the lungs. Okay, and so what happens is there's a gap between, okay, and that's called the pleural cavity. I talked about this before. So we know we have the pleura, we have the visceral pleura over the cover that covers the lungs, the parietal pleura that covers the inside of the thoracic cavity, the superior portion of the diaphragm, and the mediastinum. And between the two, we have a pleural cavity. Now, a pleural cavity isn't open like this diagram shows, but what happens is the visceral pleura is sort of against the parietal pleura. There's a small amount, a thin layer of fluid and film that sits inside here, okay? And what that does is sort of holds the two together. It's like when you take if you're washing dishes and you stick one glass inside the other and there's water, sometimes you have to have trouble getting one out. Or if you take two glass slides, like microscope slides, put a drop of water on, drop one slide on the top, it's hard to move them out. simply because what happens is that there's almost like it's not like glue, but it's like an adhesion that actually holds the two together. So basically what happens is then when the ribs go up and out and the diaphragm goes down, because that visceral pleura is sort of sucked to the parietal pleura, the lungs will, because the visceral pleura is on the surface of the lungs. So if the parietal pleura moves down, the visceral pleura sort of like, because of that adhesion, stays attached to it. It'll slide because, again, it's not like a glue. It slides with it, but what that will do is it pulls the lungs up and out, opens the lungs, and that's what allows the air to come in, like we talked about with the pressure inside the lung is less than the pressure, the air pressure outside. And so therefore air is going to go down the trachea, down the bronchi, and fill the lungs. Okay, and basically that's an important thing. Sometimes what happens is if we have a puncture wound to the chest, there might be a hole in that pleura, and air gets in that pleural cavity, and that's called a pneumothorax. As pneumo means air, thorax means chest. And what will happen is the lung will start to collapse. So instead of a lung like this, all of a sudden the lung will start to collapse. And you'll see a little collapsed lung. This area out of the outside is going to be all just filled with air, and the chest cavity fills with air. And the bad part about it is as the chest cavity fills with air, it's like filling up a balloon. What sits right here? The heart. It starts to push the heart away, which then results in a problem in regards to blood leaving or entering the heart, which then becomes a significant problem. What they do is they stick a tube inside the chest cavity called a chest tube to drain the air out. And they leave it in there, they attach it to a suction and it stays in there for a while. Okay, so that's a little bit about that. And pharynx. Okay, pharynx is basically the throat. Okay, we had this one before. Pharynx is basically the throat. If I look at the throat here, I could divide the throat three ways. Behind the nose is called the nasopharynx. Behind the mouth is called the oropharynx, and behind the larynx is called the laryngopharynx. Okay, three different areas. So that's the pharynx. Okay, nasopharynx behind the nose. Here's the nose. Oropharynx behind the mouth, and laryngopharynx behind the larynx. Sitting in there, piece of cake, easy. Okay. A pulmonary parenchyma would be my next word. Okay, pulmonary parenchyma. We'll get down to this, to trachea. So we're done with pharynx. Pulmonary parenchyma just means the tissue of the lung. That's all it means. Okay. Guess what? That's one's probably not going to show up on an exam anywhere. It just means the tissue of the lungs. Respiration. We talked about respiration, internal and external respiration, and that's that mechanical process of moving gases and moving air. And then finally, we have the trachea. Okay, and the trachea is basically this area right here. Here's the larynx. Here's that thyroid cartilage we talked about. Here's that cricoid cartilage that we talked about, and here's the trachea. And the trachea you can actually feel. If you feel the thyroid cartilage, you feel that cricoid cartilage. Below it, you can actually feel these cartilage rings. And like I think I mentioned in the last video, here's the trachea that sits like here, okay? And right behind the trachea, I have the esophagus that sits right there. These cartilage rings that are on the trachea only go part way around, okay? Because they can't go back in here. If they go back in there, it's actually going to interfere with the swallowing, okay, with food as it goes down the esophagus. The esophagus is a muscular tube, and it's basically flat. The majority of the time when we're not eating, it's flat, it's closed. And when we eat, it's going to allow it opens up, that muscular tube opens up to allow food to go down. But if there's cartilage in there, it's like going down rungs of a ladder. So it's really not very productive. So the cartilage does not sit back there, okay? It only sits around the 2/3 of the way around, okay, until it gets back to the esophagus in the back. Anyway, that's the trachea. Trachea we know is the windpipe, okay? That's what we know about that. And that gets me just to the vocabulary words I think that are really important for you to know at this point. Again, a lot of them were very similar to the word roots that we had before. So basically now, guess what? You've done them twice, many of them. There's a few new words that we had in there, hilum, cilia, and stuff like that. But a few new words, but a lot of the stuff has been a repeat. So now you're able to see it a little bit more, and you understand it hopefully even better now than you did before. So until next time, and next time we'll have another little video, which we'll start to talk a little about conditions. So, we'll talk a little medicine next time, talk about what some of these conditions are in the lungs, just in case you have an interest in that, and talk about some of the infections, talk about some lung conditions like chronic obstructive pulmonary disease, cystic fibrosis, and stuff like that. And we'll talk and use medical terms, so you'll be able to use some of the vocabulary terms. So before you go to the conditions video, make sure you go over both the word roots and the vocabulary, because a lot of the words we'll use will be, in regards to conditions, will be some of the words we've had. This way we're actually using this vocabulary now a third time. Okay, so anyway, until next time, be safe, be healthy, and have fun learning, this medical terms. I think it's a lot of good stuff. So talk to you later.